Good morning, guys. My name is Ami. I am a second year. So thank you for listening to my talk. It will be a quick one, so let's do this. So we are going to talk about schistosomiasis, diagnosis, and management. I am sure you all have heard of it before, but I just thought let's talk about it more deeply since it affects many immigrants and people who travel abroad. So for my objective, the first one would be just to have a general understanding of schistosomiasis, epidemiology and pathophysiology, and also to recognize the clinical presentation of schistosomiasis, how to diagnose in symptomatic and asymptomatic patient, and also treatment and prevention. So I don't have any conflict of interest. So for schistosomiasis, so back home I knew it as bilharzius, but I guess it is bilharzia, which is a German name. So it is a parasite that so it is a parasitic blood fluke, and it has an intermediate host, which is a snail, and a definitive host, which is humans. So it affects millions of people worldwide. So 250 million people, 230 million people are infected by it annually, and 700 million are at risk. And so you might ask, why would we care? Is it not a US disease? Well, we live in a connected world, and as people who work at UW, we see people from all around the world, and especially for me at the IMC, I deal with this almost weekly. So you will most likely see it, or it might also help you if you see a patient who is from sub-Saharan Africa who has all these symptoms, and you might think about, oh, what about this disease that is from there, and it may be in the back of your head. And in 2019, we had 2.1 million of immigrants from sub-Saharan Africa coming into the US, and I'm sure it is more now. So it may get more common here. For the epidemiology, as I was talking about, so there are more than 2 million people that are affected by schistosomiasis yearly, and in Africa alone, 140 million are in contact with schistosomiasis, and 700 million people are at risk in 76 countries, and it is endemic to 52 countries actually. And from the World Health Organization, schistosomiasis cause 200,000 deaths per year in sub-Saharan Africa. And as you might heard before, it is actually it is related to squamous cell carcinoma and other kind of disease of the liver as well, which we will talk about later. And so sadly, schistosomiasis is also one of the NTD disease, which is a neglected tropical disease because it affects people from poor countries and underdeveloped. So there's not much research about it, and so sadly, this is just the world we live in. And so I just put a definition of neglected tropical disease from the World Health Organization. So neglected tropical disease are a diverse group of conditions caused by variety of pathogens, including virus, bacteria, parasite, fungi, and toxin, and they are associated with devastating health, social, and economical consequences. So NTDs are mainly prevalent among impoverished communities in tropical areas like sub-Saharan Africa, and they have a very large geographical distribution. So it is estimated that more than 1 billion people actually are affected by the NTDs around the world. Next slide. So schistosomiasis have different species, and the three main ones that we learn, I'm sure, from medical school are Schistosoma mansoni, which is more common in Africa and South America, and we also have Schistosoma japonicum, which is in East Africa, and then Schistosoma hematobium, I cannot say it, hematobium, which is in Africa and Middle East. So this is just uh, a map of the global distribution of schistosomiasis. As you can see here, it is mainly in sub-Saharan Africa and some part of the South America, and you can see here in part of Asia. So I'm just showing you guys some geography. Just kidding. Anyway, and this is my country here. Nice. Next slide. And actually, no, I'm not done with this. As I was saying, it affects sub-Saharan Africa, and it is mainly on the rural area due to lack of clean fresh water, because there's like lake and stuff, and people just use it to bath, to wash clothes, and the snail needs this fresh water to live, and so it requires all this condition for schistosoma endemic infection to happen. So you need the water, you need the snail, and then of course a definitive host, which is human. So besides people living in those endemic area, travelers are also exposed to schistosoma as well, because with when they go to those areas, they are in contact with the fresh water, and that can cause a risk for schistosoma. And there actually has been an outbreak of tourists coming to Africa getting schistosoma, and then they go back to their home countries where the snail happen to be there, and then you have some outbreak of schistosomiasis. So there was one outbreak in south of France a few years ago. So the species can also be differentiated by the shape. So I'm sure you guys are familiar with this image. So you can see that the Schistosoma japonicum is like a round in shape, and then you have the hematobium, which is also more like elongated, and the Mansoni have a more characteristic that are like more specific for them. So you can see this kind of sharp edge that is very characteristic for Schistosoma mansoni. This is just a slide that I found in the CDC on the CDC website. So as I already mentioned before, we need for the life cycle of schistosoma, we need a definitive host and intermediate host. But for the life cycle, I guess let me go back to here. So as I was saying, we need conditions to be met for schistosoma infection to actually happen. So we need the intermediate host, which is a cell, and a definitive host, which is a human, and we also need fresh water that is in contact with the human host. And the cercaceae are released from the snail in the water, and it is what actually get into contact with the human skin and enter our bodies, and the cercaceae is going to migrate to the liver and so on, and then it will be released in the pee or stool and in the same water, and then the snail again, and then human. Yeah, I have a better representation than my words that I'm using, so I just pull up this image here. This is the life cycle again from the CDC website, showing you here. Just start from the beginning. So here you have the eggs that are shed from the feces or urine of humans, and then the eggs hatch and they are going to release the miracidae. So these are the snails, and from there they can actually live like a few weeks in the snails, and the sporocyte, as you can see here, are going to be they are so the miraceae become sporocyte in the snails, and then they are released as cercaceae in the water. And here the cercaceae are what penetrate human skin. And from there, you can see that it affects the liver and many organs. It go to the blood, the portal blood vein, and then it's going to mature into adult. Here you can see a pair of schistosoma. So this is very interesting because the male has a groove where the female just like lay down on it, and then it's going, to release eggs from there. Just very interesting, I found. And then so on and so on. So it is like a whole cycle of just different, developmental steps happening between the tree host and the fresh water. Let's see. And also, the adult worm can live in the liver for up to 5 to 7 years, but also there has been cases of people having schistosoma in their body for up to 30 years. So for the clinical presentation, there is not like a specific symptoms of what's going to be like, oh, this is schistosoma. There are like the symptoms vary depending on the age of the primary exposure, the intensity of ongoing exposure, and also the development of immunity against, repeated infection, and also the genetic susceptibility, because people who are from the endemic area also they develop this immunity against it because they are in contact with the schistosoma from early on, compared to, let's say, a tourist who never been in contact with it. So they are more likely to get something called acute infection, which are more symptomatic compared to somebody who's from those area. Let's see. And of course, there's also something called the burden of disease. Sometimes if you are exposing yourself to the parasite over and over again, you might actually have a higher burden of disease in your body, and that is more, that is harder to treat compared to just having it once. See, and something also interesting is that the adult worm is able to absorb host protein, so then it can coat themselves with their own antigen and evade the immune response, and that's why you can see people having schistosoma in their bodies up to 30 years because the immune system just cannot see them as easily. So as I was talking about earlier, this is acute infection, something called Katayama syndrome. So the name is from a region in Hiroshima, Japan. It is where the first Schistosoma japonicum was first found. So this one is more symptomatic. So people have like inflammatory symptoms with fever and chills, and also some skin changes. And because of the hypersensitivity a reaction to of the immune system against the schistosoma, there's like more inflammatory markers as well. And there's something also called tumor itch, which is skin dermatitis caused by the schistosoma. So it is caused by the penetration of the schistosoma on the skin. So it's called like this dermatitis that is not very specific because it can it's just a dermatitis, so it's kind of like there's no specific findings that is going to point us to schistosoma. But if you have somebody who swim in the water and then started having this itch, maybe think about that. There even has been some talk about that if somebody swim in the water and they dry themselves very well, it may decrease the risk of having schistosoma, because by using a towel and just trying to dry yourself, you may prevent the schistosoma from entering your skin. But this is not really a definitive preventive thing that we do, because it's not it hasn't been proven to work as well. So any question? I guess keep talking. Okay, I keep going. And now we have the chronic infection. Those are mostly, these are mostly asymptomatic, but sometimes when people have a high burden of disease, then you start seeing some symptoms like somebody with abdominal pain, poor appetite, and then the schistosoma can also cause some ulceration around the colon and cause some polyps and, dyspepsia, all of that. And then you can see splenomegaly because of just the liver is really the main site where the schistosoma, the adult worm resides. So it can cause collagen deposition, fibrosis. And interestingly, it doesn't really cause cirrhosis, because the way I guess they colonize the liver, it doesn't affect the liver function, but just the size of the liver. So in our adult, they mostly cause collagen deposition on the periportal space, and then they activate a hepatic stellar cell. And this causes periportal fibrosis, also known as SIMA fibrosis, and it leads to occlusion of the portal vein, and then that causes portal hypertension with splenomegaly. So it can cause this shunt and varices, but the liver function mostly stay intact. And for children, you can see these images of, like I'm sure you've seen it, of African kids with like a very big bellies and having a big spleen and liver, but those are very reversible when we give them treatment, and also the liver function stay intact because the eggs just are on the perisonial periportal space of the liver. I guess I just didn't want to put that picture of the African kid with the big belly. I don't know. I guess felt weird a certain way because most of them don't have the kid face. I mean, they have the kid face exposed, so I guess they don't feel good about putting that in. I guess thought I may explain it. Hopefully, it makes sense. And then we have pulmonary complication, with cough and this and some, lung finding on X-ray, and those are also reversible with treatment. And in a very rare cases, you can have like pulmonary hypertension or core pulmonal, but that is very, very rare. And of course, you have the GU symptoms that we talked about in medical school, that somebody from sub-Saharan Africa having hematuria, all of that. So we think about schistosoma. It can also cause periuria and infertilities, especially in women. It can cause infertilities with also spontaneous abortion. And there's also been link of increased risk of STI and HIV due to schistosoma infection. I think it is just because of how the schistosoma causes fibrosis and ulceration. It makes the area more susceptible to STI because of how open those ulcers are, but not really. There's no like direct link with STI, just how the ulceration and wound would just make it more susceptible to having HIV. And Of course, we talked about bladder cancer. We didn't talk about it, but we learned about in medical school about bladder cancer and schistosomiasis. It just so the main mechanism is really because of chronic inflammation, fibrosis, and maybe change on the DNA make it more likely that somebody who have schistosoma will also have bladder cancer. I mean, will develop bladder cancer on the long run if they have it on their urinary tract. And what else? Yeah. And then neuroschistosomiasis, which is actually a very rare disease, but I guess on the endemic areas, there has been cases of people having schistosoma on the brain, on the spine, and the main symptoms are really encephalopathy or myopathy. And I have some images that I will show you later on that showing the MRI finding of those. And other complications that we already talked about, HIV, STIs, and also chronic kidney disease. And so we already talked about how the changes in DNA causes people to be more susceptible to bladder cancer when they have schistosoma. And also, there's also another interesting finding is that schistosoma individuals with schistosomiasis are more susceptible to having Salmonella tufi or other Salmonella. I couldn't really find the mechanism of it, so just interesting finding. And yes, it can of course lead to anemia due to chronic disease, malnutrition, and of course affecting children growth since it is very severe. Sometimes infection because people can have a very high parasite burden and it can affect. So this is just some finding on up to date of pseudopolyps due to schistosoma hematobium on the bladder here. You can see them here. And this one is pseudopolyp on the rectal colon. So here we see the MRI findings on the spine. As you can see here, you have these nodules on the spine that are due to schistosoma, and it's not very clear here, but you can see some calcification of the bladder wall as well. So now we can talk about diagnosis. How do we diagnose somebody with schistosomiasis? So as I was saying earlier, it is mostly asymptomatic. So how do we diagnose this? So for people who are immigrant or who travel to those endemic areas, the main test is really the antibodies of the schistosome antibodies in the serum, but it cannot really distinguish between past or ongoing infection, and it cannot even tell you the parasite burden, but you can do a urine ova or stool, and it can actually show you that if somebody is having active infection because you can see them in the, like you can see them directly. So you know that this person is having active infection. And what else? And of course, the serum antibodies is more sensitive for a chronic infection. Here, so for symptomatic patients, so if somebody we suspect have a long standing infection, the serum antibodies are more sensitive. And I learned something actually interesting from people in my clinic at the IMC. Apparently, it is better to do a mid-morning collection of the urine. I guess I'm getting ahead of myself. Okay, and for early infection, you can do a PCR testing of the schistosome and the stool as well. So yeah, they were saying that doing a mid-morning collection of the urine is more specific. I guess it's more sensitive because when somebody wake up during the day, the eggs are very sticky, so the urine sample might not have enough eggs. But if you do it in the midday, they are more likely to be, expelled from the bladder. But then if you do it later during the day, uh, you might not find them because they already are all expelled already. So just doing it midday is more, I guess, sensitive to finding the eggs in the urine sample. So yeah, so we can do the serum antibodies testing and also do the eggs detection in the feces and urine as well. And for early infection, molecular testing with PCR to check for the DNA of the schistosome is more specific. Just because during the early infection, there's not enough eggs. So sometimes if you just want to see them, you might not see them as well. I mean, the parasite burden is low, so you might not find it compared if you do a PCR testing. So, and then for symptomatic screening, and I guess we already talked about. So this is just a next slide, a continuation of what I was talking about. We can also consider doing imaging for symptomatic patient. For like, I would say it's mostly like, let's say somebody have a seizure, or let's say somebody have a splenomegaly, and they are coming from those areas. Maybe let's keep schistosoma on the back of our mind. But the imaging finding are not specific, so you still need to do the serum antibodies or the urine, or very like rarely you will have to do a biopsy or check the CSF for PCR. Now we can talk about treatment. So Contal is the main treatment of choice, and it is actually a very safe drug, and it doesn't have many adverse effects really, besides just having dizziness, headache, abdominal pain. And this symptom might also be due to the um, the parasite dying, and our immune system just is more reactive to that than actually being a side effect itself. And so because the praziquantel actually affects the membrane by increasing the calcium permeability, so it causes muscle contraction and paralysis. So it's just going to release all the content of the parasite in our body or the eggs, and that causes us to have this immune reaction. So people sometimes think it is a side effect, but it is more likely due to how our body react to that. And yeah, so as I was saying, it is a very safe drug. You can even use it in pregnancy, or people who are lactating. There have not been any adverse effect found, and it is very rare to have true resistance to praziquantel. So it is a category B drugs. There is no contraindication for pregnancy and lactation. And this one I talked with our pharmacist, Zerin, at the IMC clinic, because he dispenses this drug daily, and he was telling me that because of the side effect, it is better to advise the patient to take it at once, because if they take, let's say, half of it and then they have this adverse effect, they might not take the other dose, and that can affect the I guess it can affect the eradication of the parasite. So you have to advise them to take them all at once. So for people from sub-Saharan Africa and maybe South America, so those with schistosoma hematobium, schistosoma intercalary, I don't know how to say this one, or schistosoma mansoni. So the dose is 40 milligram per kilogram a day, and you just give it as a single dose. Very rarely you have to do it in two doses. It's like, let's say somebody is very overweight, then it becomes like so many pills. And he was telling me to also like give it between, so if you are going to do two doses to give it like 4 hours in between because the half-life of the drug is very short. So take the first dose, like say in the morning, and then 4 hours later take the second dose. And for those who are from who are more susceptible for to schistosoma japonicum, the dose is 60 milligram and divided to 2 or 3, just because 60 milligram is a lot of pills. Yeah, so that was what I got from Zeril. And interestingly, I was talking about it yesterday, and then I was actually prescribing it to one of my patients who had schistosoma. So who to screen? Immigrant refugees who live in, who have, even those who have lived here for more than 10 years, I will still screen because people go back and forth between countries, and also because schistosoma can live in the body for so long, and some people might not have never been screened, to just screen most people. And also you have a traveler to endemic area. I'm sure you might have patients who want to go visit those places, so just to educate them, and maybe when they come back, try to screen them for schistosoma. Also for refugees, sometimes they are presumptively treated before they come to the US. It's part of their immigration process, so they all get all this anti-helmetic uh, treatment, but it's not all of them. So just screen most refugees and immigrants that you see, and also travelers. So prevention, well, there's no vaccine against schistosoma. I mean, it is one of the neglected disease, so it makes sense. So maybe educate your patient who have to travel to those area about avoiding fresh water and drinking safe water, and also preparing their own bath and drying well after exposure, even though it's not really proven to to stop the penetration of the parasite, but it can minimize it. So this is, I guess, that's what I have for you guys. So mostly schistosoma and the main treatment, praziquantel, and who to screen and how to prevent it. These are my references, and I want to say thank you to the people at the IMC who see this daily. Genji, Duncan, David, and Zaran, who is just an expert on so many things. So if you have any question, let me know.
Hey, Ami, I had a question. Also, Ram is adorable. Um, when you're seeing patients like this in clinic, are you mostly seeing asymptomatic individuals who you're screening once they've immigrated, or more symptomatic cases?
Mostly asymptomatic. And also, I usually just do the serum antibody testing, and when it come back positive, I just talk to them about maybe doing the urine testing, which is more specific for active infection. But most of the time, I will just treat them with the praziquantel, and they are very familiar with the disease, so they will take the medication without any, you know, resistance. So, and but if you say schistosomiasis, they don't know what you mean, so you have to say bilharzia or bilharzios.
Do you recommend that if someone in the household is infected, that that everybody in the household be treated as well? So you educate people on that?
Really, I haven't. I really don't know, because I don't think there is any recommendation for people to treat due to just having somebody in the house, because the main um um I guess the main way that it is that you can have it is when you are in contact with the fresh water, but not like human to human. contamination.
I had a question. For people who do travel back and forth to like their home country, do you screen them at routine intervals, like every time that they come back, or do you just kind of do it once and if it's negative and they're asymptomatic, do you not repeat it?
So if, let's say they are, I mean, that's actually a very good question. So if it's negative, right, and they didn't get the pregnancy consult, they go back home. If they come back, and we do the test again. I will do the test again when they come back, but I wouldn't do it like the first 3 months. Let's say like they come back 6 months later, then we can do the test just to be safe. And as I said, some people would just take the medication even before getting the test because they just know this medication so well back home. There is actually this plan for the World Health Organization to eradicate it. So they just give the medication to everybody, either you have it or not. But for me, I am in the US, just like I cannot just be giving people all the medication and be like, just take it. So I would maybe wait at least like 6 months or a year before we test again, because as I said, the early infection, you cannot really find it on the serum or on the urine as well. I hope this answers your question.
Hey, I had one other question. Back in Mauritania for you, were there any efforts to like try and kill off the parasite before it infects people, kind of like eradicate it in the environment, or is that just like futile and silly?
I don't think they did. I really think they just give people medication because back home when I was growing up, it's just like, oh, you itchy, here, take anti-helmintic medication, because maybe it is a parasite. And so there's not really any plan of like saving people from it. It's just like, let's eradicate it by giving people medication, but that's not really the answer.
Makes sense. Thanks.
Anything else, guys? Well, thank you. I'm gonna go take care of my baby now.
Thank you so much, Ami. Uh, we will take a 11-minute break and we'll be back at 10:45 for John's house staff meeting.